Hello, and welcome everyone to the scientific seminar this evening titled Dyspareunia, Reviving the Lotus from Within. My name is Logan Singham, and I shall be the moderator for this evening. Today with us, we have two esteemed speakers to speak about the different treatment options for dyspareunia and vaginal dryness, especially for women experiencing menopause. The first speaker this evening would be Datin Dr. Umul Abdul Hakim. She has 22 years of experience in the field of obstetrics and gynecology and is the director and consultant clinician at Hospital Umrah. In fact, she's a co-founding member of Hospital Umrah. She also has a professional diploma in aesthetic medicine. She's an advocate of Sharia-compliant aesthetics treatment and, of course, qualified clinical hypnotherapist as well. Dr. Muhammad Rafi bin Datuk Muhammad Faisal, who is currently the director and CEO of Hospital Umrah, also a co-founding member with more than 20 years of experience as well, has also a professional diploma in gynecology and aesthetics, and also an advocate of the Sharia-compliant aesthetic treatments. And importantly, he is also the chairman of the Aesthetic Gynecology Subcommittee at OGSN. Dr. Muhammad Rafi will be our second speaker. Together, they have developed a formidable reputation of good clinical practice and have continuously updated themselves in the frontiers of technology within their respective fields. Now, before I pass the floor to Datin Dr. Umul, I would like to go through some housekeeping rules, if you don't mind. Number one, participants can ask questions in the comments section on YouTube, Facebook, or Instagram, depending on which one you are on. However, the questions will be answered by the panel only after the end of the talk. If the speakers are unable to provide an answer during the live Q&A session, which we will have later, the organizers will reach out to you personally after the end session. Now, coming to claiming of the CPD points, please watch out for a keyword which will be flashed at the bottom of the screen during the talk. This keyword will be used to claim your CPD point by submitting your details in a link to be presented at the end of the talk. You can also find the link in the comments section on YouTube, Facebook as well. Please do fill the CPD form within 2 days of the talk to expedite the process of redemption and make sure all your details are keyed in correctly. I repeat, watch out for the keyword which will be flashed at the bottom of the screen during the talk. Now, without further ado, I would like to bring on Datin Dr. Umul for her session on menopausal symptoms, sexual health, and women and men's dilemma. Dr. Umul, please.
Hello, good evening, everyone, and thank you, Logan, Mr. Logan, for that very kind introduction. Suddenly, I feel very old. Just so that you guys know that I actually started practicing as an obstetrician and gynecologist, having my qualification in the year 2001. That's a very long time ago. So let's get on with the talk. So who better to talk about menopause than a person who's undergone menopause or who is undergoing menopause? What we're trying to bring forward today is that menopause and menopausal symptoms, especially when it's related to genital urinary symptoms or menopausal symptoms like vaginal dryness, is actually a sexual dilemma. And it's not just a dilemma which involves the female partner, but also the male partner gets involved. Because husbands must understand what the wife is going through and how they can help alleviate or alleviate the issue or offer help and support. Next. Next slide, please. Okay, all of us know about menopausal symptoms. Now, menopause is just another part of our life, meaning that we are born, we go through periods in our life, menarche, then we go into our reproductive age, and then we achieve menopause. And I would like to say the word achieve menopause instead of achieving menarche, because it is actually an achievement when we have come that far in our life as a woman. And our reproductive function has reduced. And now we are entering another era. With the current health situation, where a lot of women have got more longer, fruitful life, and we find that almost more than 50% of women in most developed countries would spend more than 50% of their life in the postmenopausal era. So things like hot flushes, sleep disorders, mood swings, dyspareunia, depressive symptoms, alteration in your energy level, exhaustion, palpitations, recurrent urinary tract infections, symptoms like joint pains, osteoporosis, your hair becomes more thin and brittle. And this is so easy. You can take pictures of when you were 20 years old and you compare them with the pictures that you have now, and you would see that the texture of the hair becomes less thicker, becomes more thinner, more brittle. Your skin becomes dry. It's loss of elasticity, and there's only so much things like plastic surgery can help. Certain things, it's very difficult to just turn back the clock and go back to as you were when you were 20. But the one that we would like to concentrate more about today, it's about the genitourinary symptoms that are associated with menopause. The main symptom would be vaginal dryness, sometimes unscheduled vaginal bleeding, especially after intercourse, pain during intercourse, loss of libido, feeling a sensation of discomfort during intercourse, or even when the patient is just sitting there doing nothing, there would be a sensation of burning sensation, or even when they're taking a pee. And so this might be confused with urinary tract infection, and we find a lot of women in the menopausal age group come forward for what they perceive are actually urinary tract infection symptoms, and they have been given multiple antibiotics by multiple doctors, because all those doctors forget that they are actually in the menopause age, and some of these symptoms may not necessarily be due to a urinary tract infection, and repeated antibiotic causes a lot of havoc and makes the situation even worse. So we find that the first thing you have to do is to rule out urinary tract infection, do a culture, for example, and that comes out as negative. Then think seriously that she might be having genitourinary syndrome, which is associated with menopause. So this has an adverse effect in the quality of life. If I have got recurrent, what I perceive as recurrent urinary tract infection, which doesn't seem to be going away, I've seen 5 doctors and all 5 have given different kinds of antibiotics, and I'm still having the symptom. And none of the doctors can actually give me something to relieve my symptoms. I start becoming very depressed. And as it is, as I am entering the menopausal age, there are some mood changes which can predispose one to depression. That makes it worse. Next, please. So we know that the vagina ages, just like your face ages. I've got gray hair here, so that is also aging process. The skin ages, everything ages. So we know that the vagina ages, and the vaginal microbiome, especially lactobacillus, is highly dependent on estrogen levels. So the higher estrogen levels you have, the more healthy bacteria there is in your vagina, because the pH is balanced, and that is a conducive environment for lactobacillus to grow. And lactobacillus are the good guys, the guys that you want to be inside your vagina. And in menopause, there is a decrease in the lactobacillus. There is a decrease in lactic acid. There is a decrease in hydrogen peroxide. And there is alkalinization of the vaginal pH. So the pH changes from a very acidic pH to a alkalinic pH. And this predisposes one to anaerobic bacterial infection. And so this makes the symptoms of genitourinary syndrome in menopause worse. And you forget that aging is also associated with DNA methylation disturbances. And one very, very, very important supplement that you can use is the simple folic acid, because expression of estrogen receptors is beta is decreased during menopause. And this association between estrogen and DNA methylation, that means the lesser estrogen you have, um, and there is more disturbance in DNA methylation, is found in women with low serum folate levels. And because of this, there is impaired mitochondrial function in the case of estrogen deficiency, and this further accelerates the aging process and further hastens vaginal aging. Next slide, please. So remember that when you want to give your patients a supplement, whether it's male or female, folic acid is a very good place to start. Next slide, please. Next slide, please. So we know about genitourinary syndrome of menopause. I just spoke to you in a couple of slides ago. And it's a progressive disorder. So menopause doesn't just happen when, say, 50 years old and it stops there. It gets progressively worse. It exhibits its symptoms more and more away from peak estrogenic activity. And because of that, there is a broad spectrum of signs and symptoms. And in treatment of the genitourinary syndrome of menopause, our main aim is to achieve relief of symptoms. One, if you explain to your patient why they're having this symptom, you explain to the patient what are the relieving factors, they themselves get relief. That this is not something in their head, but this is something that is based on science, on medical science, and there is something out there for them. So again, with genital dryness, decreased lubrication, decreased libido, discomfort during sexual intercourse, unscheduled vaginal bleeding, decreased arousal, irritation or burning or itching of the vulva vagina, and dysuria mimicking urinary tract infections, and urinary frequency and urgency, again mimicking urinary tract infections, when indeed they do not have any urinary tract infection at that moment. Next slide, please. So you have to be aware that this term maybe did not come when we were studying in medical school, because it's a new term that was coined in 2014. And sexual health plays an important role in a woman's life. Once again, remember what I said earlier, more than 50% of women in the developed world or in the developed countries will have more than 50% of their life in the postmenopausal state. So women need to have more self-confidence, especially when their sexual health is in question. Next slide, please. So this is a local study that was done at UKMSC, and we find that 85% of women complain of female sexual dysfunction, with almost 2/3 exhibiting sexual desire disorder, which includes less libido. And again, 2/3 would have sexual arousal disorder. They find it harder to climax. They find it harder to achieve an orgasm as when they were in their 20s. And more than 1/3 would have issues with vaginal lubrication. And roughly, according to a local study, only less than 2% will have sexual pain and disorder. So we see up there female sexual dysfunction in many ways or many forms would affect up to more than 2/3 of women in the peri or postmenopausal age. Next slide, please. And so this is important because this is something that women don't come forward and ask for help. And this first talk that I'm giving is just to give you a broad idea about GSM, genital urinary symptoms in menopause, and the occurrence in our local setting. So vaginal dryness, if you were to see, and sexual problems and bladder problems would be a majority of the symptoms that patients complain, in addition to other menopausal symptoms like joint and muscular dysfunction, discomfort, physical and mental exhaustion, sleeping problems. But you find a lot of women actually have got vaginal dryness. Now, one issue that we find are that women are not coming forward to ask for help. We think it's just part of aging, it's just part of growing old. Why should I go and see a doctor? Doctor might think I'm being very fussy. So we don't come forward. And this forum is so that you know and you can open a discussion. So sometimes I see perimenopausal women or postmenopausal women in my clinic, and they are still sexually active, and I ask them a simple question. How's it going on sexually for you? And it's like opening a door to a Pandora's box, because some women would just be in tears and some women would just open up, some women would just close and say, I didn't come here for that. And so we know, and we can read a room, we know how open a person is up for discussion. Next slide, please. So please, if you see a peri or postmenopausal woman and you feel it is appropriate, and if they've not come forward for this, but for coming forward for other things, it is there as an invitation for you to question your patients and to be more holistic. All right. So again, another local statistics that was done in Klang. And here we see that only 25% of women sought treatment for symptoms relating to menopause or sexual dysfunction, and only 20% of them took hormone replacement therapy. And this shows that you know that it happens in 85% of perimenopausal women, but only 25% would actually seek treatment. Next slide, please. So that is my last slide. So basically the take-home message for me would be open with your patients, read your patient's mood, see how comfortable they are talking to you for symptoms related to menopause, especially sexual function. If you find that the patient is open, there are many avenues and many modalities of treatment out there, which we will talk about in the next few slides, that you can actually offer to your clients, being more holistic, that it's not just medical assistance they require, but also psychological and relationship help, because nobody can do this alone. Like I said, menopause just doesn't start when you actually stop having your menses. Say your last menses was at the age of 50. It's a chronic, ongoing process. Thank you. Thank you for your kind attention.
Thank you, Latin Dr. Umon. That was quite an insightful session. I suppose it's really interesting to note that local studies have been done, and similar to elsewhere around the world, 80% of women, according to the local studies, 80% of the women have related dysfunction in this area. But unlike elsewhere in the world, it seems like only 20% of them are coming forward, according to the data that was just presented. Now, this is interesting, which means that a lot of them are suffering in silence. Looks like as healthcare practitioners, we need to encourage the discussion and to help them to come forward. That's how I see it anyway. So I hope Dr. Rafi is ready, because I'd like to welcome Dr. Rafi to share his thoughts on the treatment modalities for sexual dysfunction. So Dr. Rafi, if you are ready, I'm inviting you on board.
Hi Logan, thanks for inviting me. Dr. Umar's name is still on my screen, so I'm Muhammad Rafi.
We know you are. Good to see you.
Yeah, it's been a long time. Okay, it's the topic today that I've been given is about basically female sexual dysfunction, right? And it's been quite, I mean, we all know the theory behind it, and we all know what women face, but addressing this issue has been tremendously difficult, because very often they don't come forward. And time again, it's only because there's an inability to conceive that, they when you start digging and you find out whether it's a male factor, erectile dysfunction, or etc. Or honestly, it's almost a 50% female issue as well. I've had patients who've been married for 6-7 years who have not consummated the marriage. And it's sad to know that the reason behind it is because they didn't think it was important enough, and the only reason they wanted to consummate the marriage was simply because they wanted a child, and that's also because of pressure from the relatives and around them, right?
Yeah.
So yeah, you know. Okay,
Yeah.
let's go to the next slide, please.
Okay, take it away, Doc.
All right, okay. Next slide, please. I think Logan has introduced me, and we are Dr. Umar and I are both working in the same hospital, and we are basically dealing with the same amount of patients, same number of patients, and we share them out. So very often, actually, female sexual dysfunction is more of her forte because I think the female patients find that they can converse or actually relate to another female a lot easier. But very often, I'm the one getting the history and probably forwarding it back to her. And as you see in the slides, the main issues that are faced by females are actually one of the four, right? And sorry, I came off center. Let's share it. Right. So one of the four is about, dryness seems to be a big problem, especially among the perimenopausal and postmenopausal women. And I think we are all quite aware that very often the treatment can be quite simple. People don't even realize that they can use some of the lubricants that's available off the counter, from 7-Eleven, from whichever guardian carrying pharmacy. And it can resolve the problem to a great extent. We'll go down that a little bit later. Now, the second thing is reduced desire. And reduced desire comes on more often than as you grow older. I mean, there is a likelihood that the desire drops, mainly because of drop in hormonal levels, among the male and the females, and also as the should I say boredom? I don't know, right? But I know a lot of couples in the 70s, in the 80s were still sexually active, but it's sad to see a couple in the 30s who say we have sex once a month, and it's probably due to reduced desire. Again, let's be quite clear. If both partners are happy with the frequency of intercourse, then who are we to come and interfere and say, listen, you're having sex too infrequently? It's up to them. But I think very often that the issue is not addressed even with the couple themselves. The husband doesn't tell the wife, or the wife doesn't tell the husband that I'm not happy with what's happening in the bedroom, right? And often, I think if you go back and try to trace history and see what's going on, a lot of times it can be overcome. Maybe easy, maybe difficult, and let's not just say aging process, right? A lot of times people actually blame it on tubal ligation. They say, "Oh, I had a tubal ligation, and since then I've lost my desire to sexual intercourse," which is absolutely not true, right? It's definitely the aging process, and it needs to be addressed, and it can be addressed, and very often the treatment may not be as tough as it seems, and that will go down along the way, right? Now, reduced ability to orgasm. A lot of people, a lot of women, right? If you were to question them, maybe we should do a study on this. If you would question them, a lot of them say, "I've never achieved an orgasm in my life," and they don't know what we're talking about. And it's a little bit sad because it's because our society is such, our culture is such, we don't talk about such things. Our parents don't talk to us, we don't talk to our colleagues, and because of which we ourselves are ignorant, we pass this on to our children. But thank God, because of social media in this day and age, I think sometimes the children can teach the parents. I've got a 9-year-old son who's teaching me things that I've never heard of, and it's surprising. It's bad. The social media, the internet is bad, but in a way, it actually overcomes lack of knowledge in many ways. And vaginismus, definitely a big problem. Definitely a big problem, even among women who have gotten pregnant, who are about to give birth, and then towards the end of term, we're trying to do a vaginal examination, and it's almost absolutely impossible. And you really just wonder how are they going to have a normal birth? And we're forced to put an epidural on them, and even then, the fact that we're being examination is being done, they'll lift the buttocks, they'll move around, they'll scream, and it's a nightmare for the obstetrician. And it's I can imagine how the female is feeling, how the patient is feeling, and how the husband may actually be having trouble having actually trying to get her to conceive the first time around. Next slide, please. Next slide. So, treatment option, I think, the first next line of therapy, we all keep saying, if you're already perimenopausal or postmenopausal, go on to HRT or HRT like medications, in the form of pessaries, patches, implants, rings, and all these topical hormones as well. And nowadays, obviously, we try to go away from hormonal therapy, and we try to give alternative therapy, soy being one of them, in order to try to reduce the effect of the menopause, and hopefully with that we can actually increase their desire, etc. In regards to sex, the dryness, everything is overcome. And the hormone-free route is basically lubricants and moisturizers and hyaluronic acid, whether it's given orally or even topically. And if you look at that selective estrogen receptor modulators, right, there's a lot in the market. And the last part about vaginal rejuvenation, which I'll talk about a little later, is I wouldn't say new. It's been around for more than 15 years, but it's still very new among the Malaysian population. Somehow this hasn't caught on in our country, but it is huge in Europe, in the US, in Dubai, Middle East. It's huge. And it's just that we have been a little slow in trying to take on these energy-based devices to help. Next slide. Next slide, please. Okay. Now, lubricants and moisturizers, right? This is the mainstay, right? Very often when somebody is not in the mood and you are able to moisturize and cause some amount of lubrication, then the sexual experience becomes much better for the patient or for the person. But obviously, it's a short-term effect, and if you need to have intercourse for a longer duration of time, this thing dries up, and then you need to reapply lubricant, and it spoils the mood in the process. But it's readily available over the counter, and it can be purchased by the patients quite discreetly. So in a way, it's very, very good, right? And the lubricants, moisturizers, we should actually try to choose something that is similar in the pH and osmolarity of the vaginal secretion, and free from paraben, because what's available out there, it's so much, it's quite difficult to choose, right? And one of the good things about both of this is it reduces your dyspareunia and increases your sexual enjoyment. In a way, when you use moisturizers, your soreness and your enjoyment is actually improved. But there are risks involved, and one of the things that actually it took me some time to figure this out as well was this considerable sperm damage when you use lubricants, and if you're trying to conceive, or you want some fertility treatment, and even things that are popular that even gynecologists use to lubricate the speculum, even this actually causes some amount of sperm damage, right? And sometimes it may cause some irritation, some itchiness, some soreness, and damage to the tissue around it. It's not common, obviously, because water-based lubricants are fairly safe, but it can irritate, and definitely the issue of the sperm damage is something to be considered very, very strongly by us. Next. Right. HRT can help in sexual dysfunction. This obviously is for someone who had previously a good sexual history, and then when menopause is set in, they found that their desire was coming down. And these people will definitely benefit from HRT. But let's not forget that if somebody who was not having a low sexual drive at the age of 20, 30, and 40, at the age of 50, HRT is not going to help in any possible way, right? So let's not get that confused. And often we may need to do a hormonal profile to see if the androgen levels are low and whether that can be increased to help the sexual desire. And there's loads of things, the systemic tablets, and there's topical ways of applying the HRT. And if you look at it, I feel generally it is fairly safe, but obviously there are risks to the breast and risks to the endometrium and etc. If you're using the wrong kind of HRT, and long-term usage has always been a little bit of a taboo, and something that gynecologists are still debating whether we can go on HRT for more than 5 years or 10 years, and that's something we really, really need to look into. Next slide. This is my pet topic. I'm an aesthetic gynecologist, and it's been something that I've been trying to push forward among the general gynecology fraternity, is to consider using energy-based devices. There are many in the market, and obviously the prices is not cheap. It's definitely ultrasound machine would probably be cheaper than buying any of these machines. And but once you've actually had experience with them and you use them, you do find that there's significant improvement in a lot of patients, right? This itself will need 1 hour of my time, right? And let me be quite clear, when I mentioned the four or five different types of lasers here, carbon dioxide, erbium react, diode lasers, radio frequency, high intensity, focused ultrasound. The last two is non-laser, and the first three are the lasers. And it has shown in numerous studies that it does improve sexual dysfunction. It causes vaginal tightening. It increases the heat in the surrounding tissue and increases collagen formation and new vessels to form. And in the process, it improves lubrication and tightening. And in fact, to be honest, these machines can be actually be targeted towards the so-called G spot and even towards the clitoris to augment. They call it O short and G spot augmentation. There's a lot of terminology being used for the same thing. But by using these devices, there has been numerous studies saying that there's vast improvement in sexual dysfunction among the women. Next slide, please. Okay, apart from that, there's also a lot of injectables that are available. And this again is the domain of the aesthetic physician. And the aesthetic gynecology subdivision, or I wouldn't call it a subspecialty, but I'm the subcommittee chairperson for OGSM, right? And they have actually recognized that aesthetic gynecology should be considered as a sub of the obstetric gynecology field, right? And here, when we mean injectables, we have fillers, made of hyaluronic acid. A lot of fillers made of different things. And we also use the infamous Botox, which is botulinum toxin, right? I wouldn't call it infamous, but it has taken a lot of publicity, good and bad, over the years. And it's generally used on the face, but the help that Botox can do for you in the perineal and vaginal region is innumerable. People who have got vaginismus, and when you just touch it and it just goes into spasm, you inject Botox and you will see vast difference. We've been doing this for quite a few years, Dr. Umar and I, and we've had very, very good outcome, very, very good feedback from patients. And to be honest, it's a very, very simple procedure. It's just that when you start using things like Botox, botulinum toxin, then technically, if the patient is unhappy and you don't have the necessary papers to be able to use this, it becomes a problem, because the Ministry of Health has got an aesthetic division, and you need to get a letter of credentialing and privileging from these people to say you're allowed to do anything that is remotely aesthetic. And in this case, injecting things into the vaginal region is it's being done by people who don't hold the LCB, but it probably can open you to litigation in the future. Now, when I mean how much of damage can a little bit of injection cause in there, obviously not much. But if you were to overdose it, and there's some amount of urinary or rectal incontinence, then it can get a little bit messy. Okay, platelet-rich plasma. Sorry, is platelet-rich plasma, PRP. That's another thing that is, how should I put this? It's being widely used in this country. It's widely used all over the world. Little bit of a gray zone, little bit of a zone where the Ministry of Health does not recognize PRP for usage apart from orthopedic use. So, which means the orthopedic surgeons have been using this for more than 10 years now to inject into the joints, and they have seen lots of good outcome to it. In fact, Lee Chong-wei was one of those famous ones who actually had PRP injected into his knee, if I'm not mistaken, and then he carried on playing badminton for the longest of time. Now, this same thing, how it works is it's got some growth factor within that buffer layer of that. When you spin the blood and you get the little buffer layer that is full of platelets, that plasma region has got growth factors, and these growth factors, if you were to inject it into your face, you increase collagen, you look very youthful and very young. And the same thing is being injected into different regions of the vulvovaginal region. So I have used this in the past. I mean, I will still use this obviously, and this is where people say the O shot or the orgasm shot is basically injecting some around the clitoris, increasing the blood flow to the clitoris, and actually increasing the so-called sexual enjoyment that the women may face, because then those who are anorgasmic may suddenly find that they're orgasmic. Right? They also inject it into the vagina. They've also injected it into the anterior wall, saying that's the G-spot area. And of late, it's been also taken a new role where they are injecting it into the endometrium for women who are having thin endometrial lining and unable to conceive. And by injecting this PRP into the endometrial cavity just prior to conception, a couple of days before conception, the lining suddenly miraculously thickens and conception occurs much better. The IVF guys are using, I mean, well, they're starting to use this and they're very, very happy with the results. The same way, the same PRP is also being injected into the ovaries with the hope that, those who are having low ovarian reserves, by injecting them, you are encouraging the growth factor to help the ovary kickstart again, become youthful again, and produce much more eggs than they were capable of in the previous cycles. So the role here is innumerable, right? And I'm actually deviating from the original topic of sexual dysfunction. But what we need to keep in mind is a lot of these devices will be able to help most women with sexual problems. And apart from that, we as gynecologists should also look into this when we're looking at people with atrophy of the vagina due to menopause. It's been shown to even help in cases of incontinence, stress incontinence. In case of even urge incontinence, they've actually advised injecting Botox into the bladder. There's so much of research being done, and there's so much of good outcome that we are seeing all over again. And I think we have been held back a little bit because of all the laws and regulations in this country, which I totally agree. Because if you don't have such regulations, every Tom, Dick, and Harry will start doing things, and then he gets a bad reputation. This is one of the things that happened with aesthetic gynecology many years ago in the US, when everybody was doing it, and then there was some bad outcome, and people started saying this and this is humbug and this is dangerous, which is definitely not true. If you've been trained and you do it the right way, you will get good results. Next slide, please. Yeah, I think I'm the last slide. I think we are actually we're too fast for this, because we've been each given about 20 minutes per topic. But I feel they'll give us a little bit more time to take the question and answers, and we'll be able to address a lot of things. So I will re-invite Dr. Umar back here to give the last part of the talk.
Thank you, Dr. Rafi. It's unfortunate that we have so little time, because I think we got so much to share where treatment modalities like EBD and PRP are concerned. Maybe we should have a full topic on just that one alone, But it looks like there are many options, and perhaps clinicians have the options to do combination of therapies, maybe external and internal approach for the treatment of these kind of dysfunctions. Yeah. Just because we have a little bit of time, I just want to repeat again. Claiming of CPD points. Please watch out for the keywords, which will be flashed at the bottom of the screen at the end during the talk. These keywords will be used to claim your CPD points by submitting your details in the link presented at the end of the talk. Okay. You can also find the link in the comment section of YouTube, Facebook, and Instagram as well. And please do fill out the CPD forms within 2 days of the talk to expedite the process of redemption, and make sure all your details are keyed in correctly. I repeat, watch out the keyword, which will be flashed at the bottom of the screen during the talk. Yeah. So, okay. For the last section tonight, Menopause, an adjuvant therapy for genitourinary syndrome of menopause. I'd like to call upon Datin Dr. Umul once again to the floor. Datin?
Okay, hello, back here again. All right. So now that we've identified that genitourinary issues in menopause is a real issue, it is an issue that it may not be brought forward by the patient. A patient might not come forward and say, I have these symptoms, but it's there. And now we've identified that there are many modalities of treatment that we can use to help alleviate her symptoms and to give her relief, not just for menopausal symptoms or hot flushes, but for her specifically for genital urinary syndrome of menopause. So that is what we are going to go into now. We've identified the people who we have to address this issue with. We know what modalities of treatment out there. And menopause is a very interesting and safe solution that you can offer to your patient, especially when it comes to genitourinary syndrome of menopause. This is a term that was coined in 2014, if you recall my earlier slide, and it is a term that we are going to use more and more often, especially in the future. Like I said, you're going to see more and more women who will be in the postmenopausal age, but who are very active sexually, socially, and who would actually come forward to seek treatment. Next slide, please. Okay. So menopause is tailor-made. It's tailor-made specifically for genitourinary syndrome of menopause. We know that HRT, hormone replacement therapy, that has been there in the market or in the world since 1990s, and that is when it was first advocated as a little bit of a fountain of youth pill. So I remember in 1994, I had cousins who were undergoing menopause and who actually came up to me and said, really, can this help? You see, in 1994, I was only 25 years old. I didn't know anything about menopause. I mean, I read about menopause, but I didn't understand what their needs were. Now, in 2022, I'm 53 years old, and I totally understand where my cousins were coming from. So we do know that during the menopausal era, you are disturbed by your hot flushes, you are disturbed by your inability to function as well as you used to, your energy level goes down, and hormone replacement therapy was being sold as something that could answer all these questions. And with popping one pill, a woman undergoing menopause would miraculously stop menopause. That was what it was being sold, stop menopause, and perhaps regain her youth. It doesn't work that way, because menopause, like I have said earlier, is a chronic condition. It gets worse and worse and worse and worse as you age. There's nothing you can do about it. So hormone replacement therapy has its benefits, especially when it comes to symptoms like hot flushes. However, there are limitations. The main concern was, of course, we all know, about a tendency to develop certain cancers, especially breast or endometrium or both, while on hormone replacement therapy. Initially, prescription of hormone replacement therapy was fairly unregulated. At one point, when there were concerns about developing cancer, suddenly everyone hated it and nobody wanted to prescribe it. Now, if you were to offer hormone replacement therapy, it would be to a very specific group of patients, and it would be for a very short time. Then you have topical hormone replacement therapy. So you have hormone replacement therapy in the form of pills. You have hormone replacement therapy in the form of patches. You have hormone replacement therapy in the form of creams. And you have hormone replacement therapy in the form of ring pessaries that you can insert into the vagina. So you have many different kinds of hormone replacement therapy, but they all contain estrogen. And we know that estrogen has a tendency to stimulate tissues which it should not stimulate, especially breast and endometrium. Then you have women who totally do not like a hormone route, a hormone path, and they request for a hormone-free path, where you want to use hormone-free lubricants and moisturizers. What's the difference between a lubricant and a moisturizer? A lubricant works for a very short while, very superficially, does not penetrate beneath the skin. It's a lubricant. For example, if I'm going to take my ring off my finger and it's tight, I would use a lubricant. I might use oil, I might use soap as a lubricant. All right. And once I wash the soap off or the oil off, no more function. A moisturizer works by having this ability to penetrate into the skin, into the dermis, and exert an action longer than a lubricant. So if I were to apply a moisturizer on my skin, and maybe a couple of hours later, if I were to wash away, part of that moisturizer would have actually absorbed into the dermis and has an effect. So that's a difference. So you have lubricants. Lubricants are those that you can buy at 7-Eleven, the counter where they sell condoms. So you find many different kinds of lubricants. Moisturizers, they are specific for the vagina. Now, most lubricants are not specific for the vagina. So they are what I would call multi-purpose. You can use it at any orifice in the body. But moisturizers, you should use one that is specific for the vagina, because this has been designed to be vagina friendly, and of course it contains certain things which would help lubricate and moisturize the vagina to give a more complete action. You have also structural procedures like vaginal rejuvenation using energy-based devices. You can use a laser, you can use radio frequency devices. Then you have also plasma-rich PRP, plasma-rich platelet factors. Platelet-rich plasma. So PRP, which also can be used. So these are other hormone-free routes. Next slide, please. Or you can use Menopol, which is basically a stand-alone product which was designed specifically for genitourinary syndrome in the menopausal patient. So it's a 2-in-1 complaint relief, and it offers complaint relief, and it keeps your attractiveness. Why? It contains red clover isoflavones. We all know what isoflavones. Isoflavones are basically phytoestrogens. These are products that you find in plants that mimic estrogen or has an estrogen-like activity in the body. So a very famous isoflavone or phytoestrogen would be, a phytoestrogen contains isoflavones, and very famous one would be soya. So that everyone knows. And it's interesting because these products were discovered in certain cultures where usage of soya was very high, for example, in Japan. So they found that the women in Japan, the older women who were making soya paste and soya bean and dealing with a lot of soya, and they were dipping their hand in that tub full of soya. And the hand that was in contact with the soya paste, and they were doing this for many years, from when they were 20 until they were 18. You know, Japanese women are very active even in the postmenopausal age. They found that the skin on the hand was beautiful in comparison to the skin on their face, because the skin on their face aged, but the skin on the hand did not age in tandem with the skin on their face. And then they found that there was some special ingredient, and this was how one particular company came up with this is a beauty product, came up with a product that was specifically for the aging skin. And this was because of an observation that one of these people had made in Japan. So we know that there are many kinds of isoflavones. Soya is the most famous one. Here it's red clover extract. Then you have other things like black cohosh. Each has got its strength. Now, in red clover isoflavones, it's highly effective. And when you take it in a form of a preparation like this, it is standardized. Now, if I were to tell you to take soya, the first question is, how much soya do I take? How safe are soya? What is the type of soya do I take? Are there any pesticides? Are there any chemicals in the soya? So there are many other factors that come into play. So what this company has come up with is a highly effective, standardized to guarantee effectiveness based on 6 clinical studies, this MF11RCE red clover isoflavone. Next, please. Next slide, please. So, one of the things that this product menopause has is hyaluronic acid. I'm sure you all know about hyaluronic acid. We've been using it on the face for many years, and it's very effective. Hyaluronic acid has the ability to imbibe water up to 300 times its molecular weight. So it's like a sponge, and when it comes in contact with water, it just absorbs water. Next slide, please. So the human body naturally produces hyaluronic acid, and this is formed in the inner part of the plasma membrane of cells. And more than 50% of the total body content of hyaluronic acid is present in the skin alone. It plays a key role in maintaining extracellular spaces, in preserving tissue hydration, and facilitating transport of solutes and nutrients to cells in the upper layer of the skin. So it becomes a transport mechanism. Now, hyaluronic acid is like a sponge. It loves water. Next slide, please. So, it helps retain collagen and water. If you want to look youthful, you need to keep your skin hydrated. A dry skin wrinkles faster, sags faster. A more hydrated skin maintains its beauty, and wrinkle production is delayed. I can't say you will not develop wrinkles, but it will definitely be delayed. And that is why you need to use products which contain elements which can help hold on, absorb, and hold on to the water. So hyaluronic acid increases moisture in the skin and provides elasticity and flexibility of joints, and also aids in wound healing. Now, the orthopedic surgeon has been using hyaluronic acid for flexibility and elasticity of joints by giving hyaluronic acid injections into joints, especially joints that are worn out. Next slide, please. And another aid in helping wound healing is, if you want your wound to look beautiful, if you want say a surgical scar to heal well, you need to keep it moisturized. Hyaluronic acid decreases naturally with age, and this is because of hormones. And the decline can start as early as 40 years old. At that time, you are nowhere near menopause, but your hyaluronic acid levels start decreasing. Due to this decline, when you introduce hyaluronic acid exogenously, it may be a necessity. So at 40, we are not yet menopause, but there are certain hormonal changes that are occurring. And these hormonal changes have got a variety of effect. One of it is on the hyaluronic acid naturally produced by your body. Next slide, please. So, the effectiveness of hyaluronic acid in dyspareunia and vaginal dryness. Next slide. It is a very effective form of maintaining vaginal health. How does it do that? Remember I said that 50% of hyaluronic acid is in the skin. Now, the vaginal mucosa also has hyaluronic acid, but it loses its hyaluronic acid and it loses its water retaining ability and the ability to regulate inflammation and immune response, scarring, and angiogenesis. Remember, I told you that if you want a surgical scar to heal, keep it moist, keep it hydrated, and it will heal better. But when it comes to the vaginal mucosa and in the menopause age group, what happens is you lose hyaluronic acid, you lose your ability to remain hydrated in the vagina, so you open yourself up to more inflammation and scarring. Hyaluronic acid restores vaginal mucosal membrane surface integrity, and it offers a protection and hydration against the external environment. And that is why topical vaginal hyaluronic acid preparations in the form of gel or creams have been shown without a doubt to improve signs of vaginal atrophy and dyspareunia. So that is if you apply it topically. Next, please. Now, we are talking about low molecular weight hyaluronic acid in the form of oral therapy. And Galia actually did a study in 2014, and he took into consideration women who were about the age of 45 to 65 years old, and he actually did an analysis to look at two endpoints. One, repeated vaginal biopsies taken at baseline and 3 months after starting a oral low molecular weight hyaluronic acid. And two, by asking a self-assessed questionnaire, symptoms of atrophic vaginitis. He also added in a placebo to show the difference. Next slide, please. And in the next slide, we can see the outcome. Next slide, please. Okay, so the first endpoint was the vaginal biopsy. So he found that by giving an oral low molecular weight hyaluronic acid, so we look at slide A and slide B. Slide A is at baseline when the patient is enrolled into this trial. Slide B is when the patient is given a placebo. Not much difference. Now we look at slide C, D, and E. And in C, D, and E, this is at the endpoint, 3rd month after taking oral low molecular weight hyaluronic acid. And we look at the biopsy of the vaginal mucosa. We find that the epithelium has thickened. The cells exhibit a polygonal shape. They are more regulated with a round, healthy nuclei and a very nice, clear perinuclear cytoplasm. These are healthy cells. This is the picture of a healthy vaginal epithelium. This is not the picture of a vaginal epithelium in the menopausal women. Next slide, please. Remember the second endpoint. The first endpoint was something totally objective. And you cannot fight with the vaginal mucosa biopsy results. The second one is actually very subjective. He gave a questionnaire to these women that he enrolled. And he found that in the placebo, there wasn't much difference. In fact, there could be some cases where there was worsening of symptoms. But in the hyaluronic acid group, you find that after 3 months, definitely there was reduction in itching of the perineum. We find that patients started reporting that the burning sensation had reduced and dyspareunia had drastically reduced. So there was improvement in all scores. Next slide, please. So this is why this product has included oral hyaluronic acid in their product to make it better to serve specifically genitourinary syndrome in menopause. Because we know hyaluronic acid has got high bioavailability. It's almost 68% after 24 hours. And there is, after ingestion, there is a sustained release of hyaluronic acid and it stays in the plasma for a long time. Next slide, please. Hyaluronic acid also improves skin conditions. Okay, again, I'm 53. I'm very vain. I want my skin to look like I'm hopefully 35. So you need to use products, and skin products, a lot of them that serve the so-called anti-aging population contains hyaluronic acid. So hyaluronic acid, if you apply it topically, it works. If you take it orally, it works. It works after 3 weeks and it improves the skin luster after 4 weeks. It takes time for hyaluronic acid to work on the skin, but it works pretty fast in the vaginal mucosa. Next slide, please. So isoflavones, we know, like I have said before, basically are in phytoestrogenic preparations. And next slide. So we understand that isoflavones have got a similar structure to endogenous estrogen, and it interacts with the estrogen receptors where it exerts its antioxidant levels. Another thing that I would advise people who are eager to delay the aging process is to consume a lot of antioxidants and to avoid things that increases the free radical levels in your body. Smoking is a killer. So if you smoke regularly, you age. Your skin wrinkles, it ages. There's no doubt about it. So late nights, stress, So all of these actually increases the free radical levels, and you can counter it by antioxidants. Phytoestrogens like genistein have a higher affinity for beta estrogen receptors than for alpha estrogen receptors. The next slide, I will explain a little bit more about the beta and alpha estrogen receptors. And we know isoflavones have got an affinity to the beta estrogen receptors. It downregulates some responses of the alpha estrogen receptors. So it increases uh, the function of your beta receptors, and it decreases the alpha receptors. So they are like phytoserms. If we know what SERMs are. SERMs are selective estrogen receptor modulators. SERMs came into the picture the heels of using HRT, because HRT was stimulating the alpha receptors. And that's why there was an increased tendency to develop certain cancers. So SERMs came into the picture, into the market in response to this. So they wanted something that was stimulating selective estrogen receptors, not the alpha but the beta. And so that is why isoflavones have got a very favorable effect on the bone and cardiovascular system, as well as on the skin. And its safety profile on hormones is well known. Next slide, please. So here we see where the estrogen receptors are through the body. So we have alpha and beta. In the blood vessels, bones, and skin, they are basically beta. And these are the ones that will be stimulated by phytoestrogens. In the central nervous system, they are both alpha and beta. But if you look at the uterus and the breast, they are predominantly alpha estrogen receptors. In the vagina, they have got both alpha and beta. So if you were to take an oral hormonal replacement therapy, you would find that the most intense relief or difference in an oral hormone replacement therapy would be in the uterus, in the breast, in the vagina. But a SERM would work specifically on the blood vessels, on the bone, and on the skin. This product mimics a SERM. It's a phyto-SERM. So it works on the vagina, on the bone, and on the skin. And when you combine it with hyaluronic acid, which is where 50% of naturally occurring hyaluronic acid is, you find that it also has an effect, a good effect on the skin. Next slide, please. So next, we're going to talk about the effectiveness of isoflavones for dyspareunia and vaginal dryness. Next. All right. Now, isoflavones or phytoestrogens increase the maturation value and attenuate the vaginal atrophy in postmenopausal women. What does it mean? It means that there is increase in vaginal superficial cells, and the use of red clover vaginal cream for 8 weeks and MF11 red clover extract could increase the libido and reduce the pain during intercourse. How does it increase the libido? How does it help with intercourse? Remember that it's got an effect on your blood vessels. So if you go back to the previous two slides, please. Previous two slides. Yeah. So you see in the blood vessel, they are basically beta estrogen receptors. So isoflavones work on the beta receptors. So can we go forward 2 slides? So when it works on the blood vessels, it helps vasodilation. It helps the blood vessels, which has now shrunken in tandem with the postmenopausal stage, to vasodilate. Blood flow increases, and so a woman would actually feel more sexually aroused, and there would be consequently increased in libido. It enhances the estrogen-like effects to also promote wound healing and skin repair. So a woman who have got symptoms of bruising or discomfort, especially in the vulvovaginal area, isoflavones work wonders. Next slide, please. So we know that red clover has been studied, especially this MF11 red clover extract, where they have done studies in reducing vasomotor symptoms up to 73%, improvement of depressive moods and anxiety. Why? Because if a woman comes forward with genitourinary syndrome associated with menopause, they are confused. Like I said, they've gone to 6 doctors. Everyone said, oh, you've got urinary tract infection. They've consumed course after course after course of antibiotics. Still the same. Suddenly, you offer them something and you say, no, you do not have urinary tract infection. Indeed, you have genitourinary syndrome of menopause, and you put them on a product which is specific for their symptom, and you find that their symptoms get better, their mood increases, their depression goes away, because now they know it's not just in here. It is a science, there's a science behind it, and the treatment that you have given is very specific for their problem. You find that there will be improvement in atrophic vaginitis. Remember that earlier slide that we looked at, where there is increase and thickening of the basement membrane in the vaginal mucosa of women on hyaluronic acid, and this product, which is your red clover extract, would also improve not only the skin but also the thickness of the vaginal mucosa, which would help in atrophic vaginitis. What is atrophic vaginitis? It's basically thinning of the vaginal membranes and mucosa. So there is overall improvement when your mood improves, when your depression goes away, your sleep gets better, and of course the bioavailability of MF11-RCE isoflavones shows that 80 milligrams of red clover extract would be sufficient to maintain a constant therapeutic effect. Next slide, please. I'm sorry if I'm running behind time. I'm making up for the time that I finished faster, but we just got a few more slides, so if you bear with me. We find that clinical studies on the effectiveness of MF11-RCE on vaginal dryness, dyspareunia, and libido shows that the KPI or choriopyknotic index improves. Choriopyknotic index and chronification index are almost similar, and this is something that they look at in the vaginal mucosa, to look at the cells of the vaginal mucosa and to see what is the percentage of squamous epithelial cells with nice squared cytoplasmic edges with a pycnotic nuclei in relationship to other matured squamous epithelial cells. And normally, the peak of your choriopyknotic index, which is around 50 to 85%, coincide with the time of ovulation, and that coincides with peak estrogenic activity. So in a postmenopausal or perimenopausal women, we find that because of the effect of phytoestrogen on the beta receptors, which are in the vaginal mucosa, you find that your choriopyknotic index improves. Next slide, please. And also, it has a safety profile. It does not stimulate your endometrial thickness. And so it has a moderate effect on testosterone. And you would wonder, why do you want something which has an effect on the testosterone? We know that testosterone deficiency in peri or postmenopausal women also contributes to loss of libido, loss of mood. So we need a certain amount of testosterone. We all have testosterone in our system, be it female or male. It's just the level of testosterone differs. Next slide, please. So the conclusion would be, of course, improvement in the KPI or choriopyknotic index and chronification index by more of 45% by being selectively working on the beta receptors in the vaginal mucosa, and also increases your superficial and intermediate cells by almost 60%. And it indicates an increase in estrogenic activity. So this is what actually MF11-RCE does on the vagina, and it also helps in vasodilation by working on the beta receptors on the blood vessels, improves your mood, improves libido, and improves sexual health in the peri and postmenopausal age group. Next slide, please. So there's a synergistic effect. It's smart actually. It's actually a very smart thing to combine hyaluronic acid with isoflavones. And I think it's brilliant. I really think it's brilliant because hyaluronic acid is so important in women or anyone who is actually undergoing aging. And you don't start it when your skin starts sagging. You start using hyaluronic acid as early as you can. Maybe when you're in your 20s, on your face, on your skin. You start taking products with hyaluronic acid when the need requires. But of course, a healthy lifestyle and avoiding free radicals in your system to a certain extent helps. So hyaluronic acid with an isoflavone in menopause is 2 in 1. It gives you relief from complaints and it keeps the attractiveness. And the dose of 80 milligram of red clover isoflavones is highly effective and it is in a standardized dose. Thank you. All right. So it is safe and it is halal certified, in case you were wondering. And it's also vegetarian friendly with a high bioavailability. I'm getting a lot of hand signals here to tell me my time is up. So I'm sorry if I went over my time. Thank you, everyone. Thank you for your kind attention.
Thank you so much, Dr. Umul, for that very insightful talk. And yes, we have actually a lot to say about this product, but unfortunately, we don't have the time. So, full disclosure for all those of you who are still around, First Line markets Menopur. It's a one-of-a-kind product that has got high-quality hyaluronic acid and patented MF11 RCE ingredient that resolves the issues of today's topics. We have actually many very successful, happy clients on Menopur, and hopefully you will be able to put your patients on it as well. Yeah. So do get in touch with your First Line or Anta Pharma representatives to get more details. Yeah. So let me just check with my team if there are any questions that we need to answer. You guys, no? Okay. So as we have come to the end of our session, I'd like to thank everyone for being here. Please do not forget to collect your CPD points. And hopefully you'll get in touch with us to understand a little bit more about what we have been speaking about today. I would like to thank very much Dr. Rafi and Dr. Umul for their time, and wishing all of you a very good night. Thank you very much.
Thank you. Thank you.